We're going to be presenting some work we did that we presented at SIGAM on resident education attitudes and beliefs regarding opioid use, opioid overdose prevention. So I have no financial disclosures. So a little bit background as to why we felt so important to go and look at this topic is, as we know, the opioid epidemic is very rampant in our country right now. So in 2015, opioid overdose resulted in 33,000 deaths in the US, and actually more than half were prescription opioids, both prescribed and diversion. And according to the Department of Health here in New York City, back in 2015, 59% of it was 59% of heroin and 16% were fentanyl as causing unintentional overdose deaths. The other ones were for prescription and other types of opioids. So over 80% are all linked to opioids. So what happened in 2016 is that there was a citywide movement to provide naloxone access for the residents of New York City, providing them for clinics in all pharmacies at a subsidized price. Okay. So particularly here in IMA, we were awarded a Department of Health grant for naloxone kit distribution, and we were designated opioid overdose center. So the aim of our project was a quality improvement measure to assess the baseline knowledge and attitudes of the internal medicine residents in particular regarding opioid overdose prevention and how to counsel as well as naloxone prescribing. So what we did is over the course of last fall in 2017, there were 3 separate opioid overdose prevention and naloxone trainings. So 52 of our residents participated in this. Prior to the training, they completed a survey that showed a baseline understanding of naloxone distribution, belief of opioid overdose counseling, and other attitudes. Then the questions were then ranked on a 5-point Likert scale and measured with simple frequencies. So previous to this, the VA had done a study, and all these questions are based on their study where they looked at all their providers to see if there was any particular barrier to prescription of naloxone that they could identify. So among these questions, they talked about a lack of knowledge, familiarity, and comfort. And here are the questions listed here, as well as concerns about iatrogenic effects, concerns about impressions of unsafe prescribing, and concerns about risks of naloxone prescribing that providers might have. So basically, based on these survey results, 32 of the 52 residents completed. So our response rate wasn't as great as we wanted it to be, but nonetheless, 93% of residents had patients on their panel with opioid use disorder, but only 15.6% had ever provided a naloxone prescription or a take-home rescue kit to the patient. So huge discrepancy. So notably in our findings, the big questions were whether or not it was a clinician's responsibility to discuss opioid overdose prevention with patients, and most of our residents either strongly agreed or agreed with over 90% response rates, as well as being not familiar enough with opioid prevention strategies to discuss them with patients, also showed about a little over 60% with agreed and strongly agreed that they were lacking in this knowledge. The other things that we found were if residents felt they were knowledgeable about when a naloxone rescue kit is indicated, and 56% disagreed and 6% strongly disagreed, as well as residents who did not feel familiar enough with naloxone administration to discuss it with patients. Over half of them felt that this was a problem for them. So in regards to our other questions regarding the iatrogenic effects, some notable things were discussing prevention strategies with the patients. The residents felt that maybe this would send a wrong signal to the patient that they're not trusting the patient and could influence with. And so actually 18% of our residents felt neutral about the issue and 6% agreed. So this is also a problem because we want to engage our patients as much as possible and do what's right for them. And then our residents felt that opiate users would be less likely to seek out treatment if they have a naloxone kit. 65% disagreed and 25% strongly disagreed, which was a good thing. So in this graph, it's kind of an aggregate sum of all the questions based on the different categories of belief systems and where the lack is, where is the lesion in terms of barriers. As you can see, most of it is in the lack of knowledge and familiarity or comfort in discussing opioid overdose prevention and in prescribing naloxone. For the most part, residents didn't really feel that concerns about impressions of unsafe prescribing was preventing them from prescribing naloxone to patients. And again, concerns about iatrogenic effects didn't really cause anything either. So basically what we found here was that lack of familiarity and knowledge of naloxone use, as well as knowledge and skill in being able to counsel patients on opioid overdose prevention is a barrier to naloxone prescription. And so that's affecting our harm reduction and what we're able to do with our patients in clinic. So we did identify the need for resident training, which we were piloting and starting all that. So what we would like to do as future endeavors is to assess a post-training survey to see how the training will affect and change the rates of naloxone prescription and our counseling with our patients. I'd like to thank Dr. Fu, Dr. Wang, Dr. Toribio, and Dr. Weiss for their help on this project and continued efforts, as well as IMA and the New York City Department of Health. Any questions? Yes.
Can you sense as to what the reluctance was in terms of, well, not reluctance, but what the source of discomfort was? And then for those of us that might not be as important, what the lack of engagement was? I know it wasn't a written part, right?
No, there wasn't.
Just in your experience, what, just how much is in the media, what's your experience with your colleagues?
Definitely. So I think the big part for the residents, in terms of baseline, knowing that these patients should have naloxone in theory, I think there's no lack of that knowledge there. But it's in the actual how to do the counseling. How do I prescribe it? How often how do I do the dosing? How do they show them how to use the actual naloxone kit in the first place? And so that's where, in medical school, didn't have exposure to that. And does that answer the question?
Just to add to that, there have been some other studies at Hopkins and other institutions looking at barriers, and a lot of it is time. Prescribers don't feel like they have 10 minutes on top of an order busy schedule to do that training with their patients, which is why some of the work that we're doing now is to ask our RNs and other staff to be able to provide that training. And I think also role modeling is important. So in addition to resident training, if other people in your practice are routinely doing it, it can be implemented and integrated into your primary care practice more easily in the same way that we do point of care USCs and counseling around diabetes.
So like other, I assume most studies on like attending are there prescribing issues among attending staff? Like
yeah, so actually in the study, the VA that did the same study, so it was amongst attendings, nurse practitioners as well. And in their study, they actually found the similar thing, that it was the lack of knowledge and comfort in prescription. Thank you.
All right, next we're going to have Dr. Michael Allen, who's another one of our second years. Mike went to med school at the Sacre School in Tel Aviv and is applying to rheumatology.
So
Mine is a clinical case that I presented at SIGM. Opiates not a treatment for Still's disease. It's just one of the transition. So this is a case of Still's that kind of interesting case that hopefully will teach us a little bit about, first of all, the clinical presentation of Still's and kind of the rare but severe cardiovascular manifestations, which are, Still's disease is already a rare disease, and even more rare are these kind of severe cardiovascular sequelae. We will talk about a specific one based on this case. So this is a 40-year-old guy, pretty healthy guy, no real medical history, had like anxiety. Came into the hospital, or came into clinic, excuse me, with 3 months of fevers to 101, had a lot of diffuse myalgia, kind of non-specific symptoms. He was having a macular rash along the left chest and arm, had been present intermittently for a couple of years, he said. Been called like psoriasis in the past. He'd done some steroid creams and various things. No cough, diarrhea, dysuria, joint pain, no allergies. He didn't take any medications or anything. In terms of social history, he was MSM. He had traveled to various places. He'd been in the Caribbean like a year before. He'd been in South Florida 3 or 4 months before, kind of complicating the social history. So you're thinking of a lot of kind of various things about what this possibly could be. So he went to primary care clinic initially. He was febrile there. He didn't have a rash. He got a full workup, you know, kind of a basic workup. He got a chest x-ray that was negative. He was negative for HIV, negative for RPR. They kind of gave him a, you know, viral disease, not otherwise specified diagnosis, and he got better after a couple of weeks. He went home, went back to work. He's a functional guy. He worked, he owned a business. So he worked from home, but he owned some kind of online business. Then 2 months later, started having these fevers again, severe fatigue, wasn't able to work. He was having drenching sweats every day. So he went again to clinic. They referred him to infectious disease. He had another infectious disease workup, essentially, you know, RPR. Again, they did the RPR, the HIV, in addition to like Borrelia and all of these various infectious labs. Everything was negative, and his fatigue had became so profound that he actually went into the hospital for evaluation. So when he came into the hospital, he was a little bit febrile, 101, not tachycardic. His pressure was normal. He was not septic in any sense. He was setting up 99% on room air. He looked well. Mild diastolic murmur, but you know, a little bit of diastolic murmur at the right second intercostal space, but he didn't have any joint swelling or tenderness. And he had I don't know how well this shows up, this rash, but he had this pink colored rash along the left upper chest wall and the left arm. So his labs here, not particularly exciting, really. He had a really little bit of LFT abnormalities. Again, he got his third negative HIV and RPR. He had a quant gold was negative. He had some very mild inflammatory markers. The SR and CRP were very mildly elevated, and he had a low level ANA. His ferritin was not elevated. His rheumatoid factor was negative. It had double-stranded. So then you do kind of the basic rheumatologic stuff. His double-stranded DNA was negative. He had negative antibodies for PR3 and myeloperoxidase as well. So kind of a non-specific sort of presentation. So I would like to say that, you know, it would be nice for me to say that I was sure that he had Still's disease and therefore, you know, started him on prednisone. But what happened in the ED is he actually got a CT chest. So he got a CT chest in the ED with contrast that was not remarkable in terms of his lung disease, but he had an ascending aortic. He had a 5. So I didn't order the CT chest. But no, I think the idea was that maybe he had some sort of pulmonary abscess that someone couldn't diagnose because he was just having this kind of recurring fever. I don't think anyone wrote, you know, what their specific differential was for the CT chest, but he has this ascending. So he has it. So and his lung parenchyma was completely normal, but it was notable for this ascending 5 centimeter ascending aortic, 5.3 centimeter ascending aortic aneurysm. So he was admitted after that, probably really didn't need to be admitted to the hospital, but because of his kind of profound fatigue and this whole constellation of symptoms and this new finding, was admitted to the hospital. Got an echo the next day, which showed severe aortic valve regurgitation, in addition to redemonstrating this large ascending aortic aneurysm. The rest of his echo was pretty much normal. So based on the clinical story and this fever, 101, fever over 101, LFT abnormalities, and a characteristic rash, was diagnosed with adult onset Still's disease. So this is the kind of very rare diagnosis, but there's a few different diagnostic criteria for Still's. This is the Yamaguchi criteria, which are kind of the most commonly cited in the literature in terms of for diagnosing Still's. Fever over 39, the major criteria being fever over 39 degrees, intermittent for a week or longer. He certainly had that. It actually happened essentially happened in 2 bouts for him. He had it for a couple weeks, it went away, and then it came back for a couple of weeks. The characteristic rash was he did not have a leukocytosis. He did not actually have arthralgia either. He didn't have a sore throat. He did have the LFT abnormalities. And of course, for exclusion criteria, because it is a kind of a diagnosis of exclusion to some degree, you have to rule out infections, malignancy, other clear rheumatologic diseases. So, this is so other kind of clues that people think about that are actually not included in the criteria are the elevated ferritin. People think, setting off ferritin is kind of not diagnostic, but that gives you a little bit more evidence towards Still's, and it does, specifically the glycosylated ferritin, which is a low number. It's low in Still's disease. Even with an elevated ferritin is common in an outpatient setting. He never got the glycosylated ferritin sent off. His ferritin was in the normal range, but kind of important to remember that you can still have the diagnosis even without elevated ferritin. So in his case, he had a very rare presentation in terms of this ascending aortic aneurysm. There's only case reports of aortic aneurysm being associated with Still's disease. It is not a common cardiovascular manifestation. Some of the most common cardiovascular manifestations are pericarditis and myocarditis. Those are pretty commonly cited. You'll see them in Still's. They do require immunosuppression for that. Pericardial effusion going along with pericarditis. More rarely, portal vein thrombus, aortic regurgitation. There are cases of tamponade reported, and then aortic root aneurysm, which is again really very rare, which is what this patient had. So back to him. So he started on prednisone. His symptoms got much better. He wasn't having fevers. He was able to return to work. All of his inflammatory markers improved. His LFTs improved. So he actually underwent an aortic aneurysm repair. He had an aortic valve replacement back in the fall. His valve showed maxillary disc degeneration. He now has a bioprosthetic valve. And the aortic wall did not show any active inflammation, but he had been on immunosuppression for about a month prior to the procedure. Almost 2 months, actually, prior to the procedure. He was on a very long prednisone taper. He was diagnosed in like August or September. He's now on 2.5 milligrams of prednisone still, trying to be weaned off entirely. With the long-term, if he ideally doesn't recur any sort of signs of inflammation. If he does start having inflammation again, probably would go on methotrexate in terms of steroid-sparing agent for Still's. Back to work, doing well, according to minutes. So it's a rare, just kind of for teaching points, it's a rare clinical entity. The classic triad being the daily spike in fevers, the salmon-colored rash that I showed you, and arthralgia, which he did not particularly have, but he had 2 of those 3. Most cases require steroids to achieve remission. People on NSAIDs, usually 80%, will not achieve remission with NSAIDs alone. And some cases are associated with severe cardiovascular sequelae, most commonly pericarditis and myocarditis, although you can see more rare and severe sequelae, including aortic root aneurysm. So just thanks to Dr. Weintraub, who's not here, of course, but Dr. Pegarala, who is here, for helping with submitting it. Dr. Tassio is one of my herpetology mentors, and he helped me go through the case. Dr. Pfeiffer and Fred, all the DJM for letting us come in and speak today. Is there any questions about Still's disease?
Is that sort of, I know it's like adult onset Still's in general is rare. Is there certain age groups that are more likely to get it?
So bimodal, it's like a bimodal age distribution with people being, him falling in the younger category. There's a cohort of people that are over 65 to 75 that have adult onset Still's, but the younger cohort is like 20 to 40 years old. He's roughly in that younger cohort.
I'm really curious, if he hadn't had the CT test done incidentally, what
would
other
have happened?
things would you look for? You said that he had a murmur, and on the grading of diastolic murmurs, 2 out of 4 is actually pretty,
That's-
logic.
yeah.
So I'm curious if you had anything else that would have swayed you to do more of a cardiac workup.
So the next thing probably just on the murmur alone and
Yeah.
the daily spiking fevers, they would have gotten an echo probably regardless of the CT chest. And then you would have seen, so even without that would have shown the aortic root aneurysm and it would have shown the severe AR. So that would have been probably the next thing other than just culturing him and kind of watching him, which was what we kind of were doing. He was cultured in ED, he was cultured again when he kept spiking fevers. Echo, otherwise the rest of his kind of more, occult infectious workup was negative. All the Lyme serologies were negative, and he wasn't so sick appearing that he didn't have any sort of meningitis or anything like that. He had no skin findings. There was really nothing localizing about his presentation. So I don't know what else from a lab perspective would have been done. He would have just sat in the hospital and we would have watched him.
Did he have any other symptoms?
Sweats?
Would suggest AR, so exertional dyspnea, palpitation, angina.
Not specifically, he didn't have dyspnea or really shortness of breath at all. I mean, he was bedbound. Essentially he was going through his normal life and then all of a sudden was just knocked out with fatigue. But no specific dyspnea, no angina, nothing like that would have pointed me at aortic regurgitation.
Well, and not through clothes and all that. It might have been there, been a clue. It probably was a lot sooner.
So that's
Because I wouldn't have thought that degree of
So that's the other thing with the rash.
Right. Results like, maybe we see it degenerative, right? Regular explosive, maybe inflammatory.
You'll see it like within a week, and like when you do echo a month, they have like coronary artery infections, but they'll have like spiking fevers, rash, but usually they'll have like low platelet count abnormalities and urine abnormalities, but because there is adult onset calicitis, this is not that common. But you look at aneurysms very quickly.
The other thought was like Takayasu's or something like that, causing this, large, that it could cause the same kind of picture, but with the rash. So the rash was the other presenting fact that someone could have maybe caught earlier. Obviously, hindsight with CT chest being 2020, and like him getting the echo, it's more clear now. But he's had this psoriasis, essentially, diagnosis of this rash that came and went. But I don't know, obviously that doesn't look like, it doesn't really make sense. But like he had anxiety and psoriasis, no one had really ever worked it up. He took, he probably put like hydrocortisone cream on it once in a while, and then it went away on its own. So it just never really was worked up any further.
And sometimes you do see those intermittent fever things, like, oh, it's a virus, it's another virus.
Yeah.
It'll go away by itself if you don't do anything. So that's another thing. If something keeps recurring, that's a little weird.
And he had normal LFT. So that if you would have done this workup maybe as in clinic, especially if you take out the inflammatory markers in the ANA, which you wouldn't maybe do right off the bat, he did have normal LFTs before, which kind of, if the LFTs are normal there, you're kind of really. Thank you very much.
Is that what she got?
Yeah.
Remember those?
Intubated.
Stated my students, that's all I remember.
All right, thanks, Michael. So our third presentation is from Dr. Savi Tucker, Dr. Ray Jang. Dr. Tucker got her medical degree at George Washington University and she's one of our second year primary care track residents interested in quality improvement. And Dr. Jang got her degree at UNC and is graduating tonight.
Hi everyone. So today we're presenting a case on implementing advanced access scheduling in a primary care setting. And we do not have any disclosures. So we're going to start off with a case, a 57-year-old man who's an Atlantic City casino worker. history of diabetes, hypertension, and some osteoarthritis in the knees, presents to his union-sponsored health center for an urgent care visit for acute on chronic knee pain. So as you're reviewing his records, you notice that his last hemoglobin A1C was from last year and was 7.8. And when you do a point of care testing, it came back as 10.1. Upon further questioning, you learn that he hasn't been to a doctor because his work schedule is done on a bi-weekly basis, and every time he calls, the clinic is always booked for the next 2 weeks for a regular follow-up visit. So thus he's not been able to follow up very regularly. Question is, how can we increase access to primary care for this patient? Although this is a hypothetical case, but I just want to highlight a few things. The place where it was implemented was a union-sponsored healthcare center, and also one of the things that they had to grapple with in this population, their schedule is very unpredictable, from cooks to dealers to everyone else. They didn't know their schedule until like a week or two in advance. And whenever they did have an opening, the clinic was full. So they were seeking for a solution to address those problems. So this was initially as an internal QI project that was done to evaluate how advanced access scheduling can, 1, help patient access to care, 2, clinic efficiency, and 3, patient, provider, and staff experience. Just a little bit background on the scheduling system that we have. So Mark Murray, he's like this father of advanced access model. Describe, in general, there are 3 different types. A traditional model where you have 100% booked. Then you have the carve-out model where about like 50% is set for urgent same-day care appointment, versus advanced access model is you set a specific amount aside for both urgent same days and also follow-up. So that's kind of the difference between the 3.
So as Ray nicely described, the location of this study was in Atlantic City, and this particular clinic was a joint partnership between Mount Sinai Health Partners and Unite Here Health, which is a healthcare fund for a union. Their schedule of the casino workers who are part of this union is very similar to a resident schedule, so we thought we could very much relate with them. And the second thing to note here is that as part of being a fund member, the union, the casino workers actually kind of get a say and have a voice on the patient advocacy board. And so this is why scheduling was noted to be a priority for them. So the type of scheduling system that this health center chose to go ahead with in regards to advanced access was a split of 40-60. So 60% of scheduling slots would remain pre-booked, with the ability to schedule up to 4 weeks in advance, which was also new actually. And then 40% of slots would be available on a day-to-day basis where they were not pre-booked in advance, they were open, and anyone could call in the morning and get an appointment, whether that was an urgent visit or follow-up appointment. That distinction was not made. So the steps to how this is implemented. So they follow the guidelines that were written out in sort of Mark Murray's seminal article on advanced access scheduling. So the first step really is to know your patient panel and to know where you are on the spectrum of scheduled visits. And the first step is to eliminate the backlog of those scheduled visits. So what backlog really means is that the visits that you already pre-booked months ago that are kind of sitting ahead of you, you have to take care of those, and you have to decide as a clinic that, from this particular date, we will no longer pre-book any visits. The second step was to actually implement advanced access scheduling. So as part of this, it was really important for the clinic leadership to get buy-in not only from the other providers, but also the front desk staff who would have to adapt to a new scheduling model and to a new system of their workflows. And then in addition to that, of course, it's important to disseminate this information to patients. This was pretty easy for this health center because they sort of had a unified body with the healthcare fund governing them. So that was one way that they shared it. And then there was a lot of signage in the clinic, a lot of discussion when patients came for their regular appointments that this would be the new form of scheduling. So the way in which we studied the implementation of this model was through a mixed methods analysis. So we use both quantitative and qualitative data to assess. The quantitative measures that we chose, so the primary outcome was ED utilization, because for this health center it was a significant problem. And this was assessed by looking at insurance claims data. The secondary outcomes were the no-show rates, the days to next available appointment, and net promoter score. Just to point to days to next appointment, in the literature, they often use third next available appointment because it used to be kind of the gold standard, but they're now using days to next available appointment. That's kind of just an update in how the research is done on these types of models. And then lastly, the net promoter score is a standardized way that we are able to measure patient experience. It's basically a question where they ask patients, would you recommend this health center to your family or friends? The qualitative methodology that we used, so we used a special framework that's part of implementation science that allows us to sort of get a snapshot in time of the experience of the individuals that we're surveying. So we developed two semi-structured interviews, so one geared towards the front desk and one geared towards the providers. And we chose to interview these individuals because we felt like they were the most impacted by this new scheduling model. The front desk, sort of the face of the clinic, the people who answer the phones and do the scheduling, and then the providers who kind of are the ones determining when a patient needs to be seen again. So the data that we collected through these interviews was coded and analyzed through a grounded theory framework because we also felt like that was the best to assess healthcare experience.
So for the qualitative results, our main result was looking at the ER utilization as described above, and we measured that in ER visits per 1,000 members per year. That was something was preset by the statistical analysis, like set up by the clinic. Overall, there was about a 22% decrease from implementation of phase 1, which was decreasing backlog, to starting phase 2, which was getting the actual advanced access scheduling in place. And actually, our data points are kind of limited by like this the data that was actually collected, so it only goes up to June 17th. But when we analyze it further, just looking at individual points, it actually continues to go down. So that's our primary thing that we looked at. And also just to look at, does that correlate inside the clinic? Is it other things that are also affecting it? One of the things we did look at was a no-show rate, and just to see how people are able to make to these appointments. And we see that on average, the no-show rate went from 17% to 7% after the implementation of the advanced access scheduling model. And overall, the days to next available new appointment went from 15.5 days to 0.48 days, and the days to next follow-up appointment was 15.5 days again to 0.18 days. So significantly decreased overall. And our promoter score was actually 86, which is pretty high for like a primary care clinic. Out of those clinics who actually use net promoter scores.
So the following slides describe the qualitative themes that we were able to elicit from our interviews. We chose to use quotes because we felt like it best illuminated the data that we found. And so the first thing that we noted was that in order to facilitate this model, there really needs to be buy-in from both the front desk and providers and an understanding of how this system could possibly help the individuals that they are taking care of. Both front desk and providers empathize strongly with this community, and on further questioning, we found that many of the members of the front desk actually either used to be casino workers or used to work for the health fund itself before transitioning to the health center. But the same goes for the providers who were also from the community and had actually been serving the community prior to the introduction of UnitedHealthcare Health Center. So as far as the barrier to really sustaining this model, so there's an expectation that when a provider would come in the morning and see their schedule, there should be open slots. And we were measuring this experience maybe a good 6 months into the intervention, and we noted that a lot of providers were noticing that their schedules were filling up despite the fact that they shouldn't have been. And so on further questioning for the front desk staff, it was interesting because they actually noticed that there were some face-to-face appointments that were being booked that were unnecessary. There were certain things that could have been accomplished through telemedicine or a phone call from the MA or the nurse. And so we found it very interesting that the front desk was actually attuned to this and could make recommendations on, whether a patient really needed a face-to-face or not. And then how can we sustain this model going into the future? Both the front desk and providers seemed optimistic about wanting to keep this model, and they felt like the best way to kind of address the issues that they were contending with was by continued communication. So establishing a clear way for the front desk to communicate maybe scheduling issues with the providers, and if the providers felt like, they really needed someone to come in, they communicate that with the front desk.
So overall, our conclusion was that the implementation of advanced access was associated with a decrease in ER utilization, and we understand that there were a lot of other things going on in the clinic at that time that probably also contribute to that, but we do believe that advanced access, implementing this kind of schedule, allowing people to be able to come in on their timetable, helped in that process. Also, finally, everyone in the clinic from front desk to provider agree that teamwork, open communication are the keys to success in implementing this model. And as for our next step, as mentioned previously, one of the things is we need to decrease the over demand for appointment, face-to-face appointment visits. And one of the ways that they are doing so, they're having someone who's reviewing the appointments upcoming and deciding does this need a face-to-face or can we just advise them over the phone? And they're actually using a Schmidt-Thompson triage model with a nurse who can either give patient self-management guidelines or advise them for a face-to-face consultation. And finally, continuing team building. Currently, the clinic itself is having several turnovers in staff. So this is an ongoing effort by the office manager and the medical director to ensure that each new person gets to be trained and really get incorporated into the team on an ongoing basis, and not just say today it ends here, we're done with orientation, but have that ongoing. And we would just like to thank our mentor, Dr. Lindsay Drubelt, who really, I remember working on this project with her even when she was on her maternity leave. And then Dr. Anup Rama, who is the medical director at the time of us doing this project. He has now moved on to a new position, but he provided us with a lot of helpful information. And Ms. Bahari is the current practice manager who's been excellent and great at helping us to understand everything, and all of the institutions that have supported us.